Okay, you may start now.
Okay, thank you. I want to welcome everyone to the Special Committee on Long-Term Healthcare. Today, Monday, March 27, 2023. Madam Clerk, can you please call the roll?
Alderwoman Davis, Alderwoman Boyd, Christine Ingracia,
Present.
Kathleen Holmes,
Present.
Harold Braswell,
Present.
Lenny Jones, Marjorie Moore, Laura Barrett,
Present.
Lavita Richardson, Victoria and Rory, Andrew Lackey,
Present.
Annalise Stover,
Present.
Danielle Spratley, Chris Beckley, Tasanya Johnson, Jamie Opsel,
Present.
Cindy Jackson, Ellen Usher,
Present.
Reverend Kevin Anthony, Alderwoman Middlebrook,
Present.
Alderwoman Davis, Alderwoman Boyd, Lenny Jones, Marjorie Moore, Lavita Richardson, Victoria and Rory, Danielle Spratley, Chris Beckley, Tasanya Johnson, Cindy Jackson. We have 11 present. We have a quorum.
Thank you. Hopefully everyone has had a chance to look over the minutes, so can we get a motion to approve the minutes of Monday, March the 13th, 2023, and Monday, March the 20th, 2023.
So moved, Kathleen Holmes.
Second.
Thank you. So today we are going to continue our discussion on long-term healthcare and the state of long-term healthcare. It's non-for-profit and for-profit providers, its regulators, its recipients, their demographics, race to pay, staff pipeline, systematic problems, and possible solutions. Today with us, we have guest speakers Nina Cohn and Maurice Redden. Madam Clerk, are these two people here?
Yes, they are.
Okay, can you go ahead and swear them in?
Yes. Do you swear to tell the truth, the whole truth, and nothing but the truth? First, I'll need both your right hands, I'm sorry, to be held. I can't. Okay, there we go. Do you swear to tell the truth, the whole truth, and nothing but the truth?
Yes.
Thank you.
Okay, thank you. So first we're going to hear from Miss Nina Cohn.
Great. Well, thank you very much for inviting me here today. I'm a law professor at Syracuse University, and I write on issues around long-term care. I don't have to tell you that the pandemic has exposed a series of long-standing problems in nursing home care, including regulatory failures, which have allowed nursing homes to be operated in ways that put residents and staff at risk. So what I'm planning to do today, and Harold gave me a little direction here in terms of what might be useful to y'all, is to identify some concrete things that can be done to improve the quality of nursing home care and working conditions of staff. And I'm going to break that down at the local level, the state level, and the federal level. And I'll take about 10 minutes to do that. Does that sound okay? Okay. So let me start at the local level. At the local level, I think a critical resource is your ombudsman program. As you know, ombudsmen are a key link between residents and the outside world. So one point of intervention is to build systems in a community that support ombudsman programs. And community partners can play a really big role in helping ombudsmen identify concerns and advocate for residents. So, for example, community partners can play a big role in helping recruit volunteer ombudsmen including ethnically and linguistically diverse ombudsmen who can support diverse populations. Community partners can play a big role in training ombudsmen. Volunteers come and go, so it's really important to continuously offer training opportunities. When I worked as a legal aid opportunity in a rural area in upstate New York, one service I provided as a legal aid attorney was to offer trainings for ombudsmen on basic rights of nursing home residents. And what I found is that this really helped them, empower them to understand what options were available to them, and to understand that many of the things they were asking nursing homes for weren't luxuries, but really required services that the nursing homes were already billing the federal government for. Community partners can also be a source for ombudsmen to refer out to address problems that residents are experiencing, and legal aids can be a really good partner there, of course. Now, if we move to the state level, I think a key focus at the state level really needs to be holding nursing homes accountable. And there's a bunch of different options you could be focusing on there. I'll look at a couple, just sort of tee up a couple that work within existing systems. So one important intervention, I think, is to improve the nursing home inspection process. Surveyors going into nursing homes need to have the training they need to identify problems and accurately assess deficiencies. And one concern that's been identified at the national level is that surveyors often not only have inadequate training, but they can have kind of perverse incentives. So a New York Times investigation, for example, found that surveyors are often discouraged from citing facilities for serious violations because doing so requires extra paperwork. And they're sometimes even explicitly discouraged from citing facilities due to cozy relationships, really, between the regulated and the regulator. Another important intervention at the state level is to right-size penalties so that owners and operators have sufficient incentives to provide adequate care. We know that currently penalties are, as the report that I know has been shared among you indicated, are paltry. And many times when nursing home residents nursing homes, I should say, violate federal rules that are designed to protect their residents, there's really no penalty levied. And when penalties are levied, they're usually limited to pretty small monetary fines. Now, of course, part of this is a Fed problem, right? The feds could really help by rescinding guidance that encourages states to waive financial penalties for most violations, that discourages more substantial penalties like holds on new admissions. But there's also a role for the state here in using its discretion under federal law and in using the state's own law. So I'm not a Missouri attorney, but I believe Missouri's public health statutes authorize the state to impose its own penalties for survey violations. So Missouri could also use state-specific penalties where federal ones aren't imposed or are insufficient to create the incentives needed. Of course, nursing homes and the nursing home industry are likely going to argue that monetary penalties are counterproductive because they could divert money from resident care. But the evidence suggests that if we look at underperforming nursing homes, a key reason they're underperforming nursing homes is that they are diverting the money needed for a resident care in the first place. So, for example, for-profit entities like your private equity firms that own nursing homes can use that to generate profit for related entities like management fees, leasing costs, interest payments, even if they're showing minimal or no profit on their own spreadsheets. So part of what increased penalties could do is discourage owners from doing that, resulting in more money being spent on resident care. Another thing you could think about at the state level is leveraging Missouri's nursing home licensure system to encourage better quality care. So Missouri nursing homes need to obtain a license from the state to operate. That's subject to renewal, I believe, every 2 years. And you might want to look at how you could use that process to drive quality in the state. So Missouri's regulations allow the state to consider an applicant's performance and condition licensure on it. Now, to what extent is the state really doing that? might be worth looking into. What we know from our research is that many states are not. And I'm happy to share a new paper I have coming out on that, looking at this sort of nationally. So we're looking at both when we are looking at licensure to drive quality. Perhaps you want to look at how the particular facility that's being licensed has performed in the past, but you might also inquire into how other facilities owned or operated by this individual who's applying, or entity that's applying for a license, have fared. Is this an entity that has a track record of very poor resident care? If so, maybe that's not an entity that should be licensed to operate an additional facility. I will note that, when we're looking at licensure, we could be looking at initial licensures. We could be looking at revocation of licensure. It's important to recognize that the fact that a license is revoked based on poor quality of care doesn't necessarily mean that the nursing home will be closed, right? So states have used, for example, temporary receivers to replace management in nursing homes in that type of situation. Okay, cognizant of time, let me move on for a moment to talking about the federal level and what could be done at that level. I think the really good news here is that the Biden administration last year announced a series of pretty decent proposed reforms. The bad news is that the nursing home industry has come out with guns blazing against them. And that's a very powerful lobby. And so I think it's really imperative that advocates for residents and advocates for staff also make themselves heard. One proposal that desperately needs support is the administration's proposed rule requiring nursing homes to disclose information about who owns and operates them. Better information about who owns and operates nursing homes will help states use licensure schemes to improve care. And it can also help track money flows and understand how nursing homes' true expenses sort of are. What are the real expenses versus what's actually profit? Because right now, a lot of profit can be disguised as expense through related party transactions. And that information could be really helpful if Missouri wanted to, and some states have done this already, pass a statute requiring a minimum % of revenue be spent on resident care. So you've got a couple states out there, Massachusetts, New York, New Jersey, that have done this approach of requiring minimum spend on resident care. But that's really hard to make meaningful unless you have transparency. Another Biden proposal that needs support right now is the proposal to adopt a new nursing home staffing standard at the federal level. It's long overdue. We know from research that the ratio of nursing home staff, and particularly RN staff to residents, is a critically important predictor of the quality of care residents receive. And we can look at that across metrics, whether that be hospitalization rates, whether that be the rate of pressure ulcer development, whether that be resident functional level, deficiency levels. All of that is correlated with staffing levels. And so it's really important that we have a minimum staffing standard and not simply the current sort of nebulous, if you will, requirement of sufficient staff, because that hasn't been working. Without a minimum staffing requirement, I fear that nursing homes will continue to have just an incredibly strong economic incentive to keep staffing levels low. Because staff costs, and we know this, right, are a key driver of the overall cost within the industry. And that incentive is particularly strong for our for-profit entities, which comprise over 70% of the industry. Indeed, if you look at the business model for for-profit facilities, a key part of that business model is to have low staffing levels. And that helps explain why, on average, for-profit facilities have more deficiencies than either nonprofit or government-run facilities. And I will just say, as we think about sort of the relationship between what you can do at the federal level and the state level, if the federal government doesn't and proposing a meaningful minimum staffing requirement. Not all is lost, right? Missouri could impose its own minimum staffing standards. If it does so, let me encourage you, and I think you probably know this already, to not look just at the ratio of direct care staff to residents, but also look at staff mix very carefully, and particularly focusing on RN staffing levels. Because one thing we're seeing, for example, with the real estate investment trusts, is them shifting from RNs to LPNs to save resources, and that coming at the expense of the quality of care that residents are receiving in these RE-owned facilities. Okay, so that was just a lot in a very short amount of time, but I will end there. I hope this gives you some ideas of maybe some of the things you could think about cobbling together from a regulatory perspective to improve nursing home care. And I'll stay on as long as y'all want. Thank you for your time.
Okay, thank you. I'm going to go to members of the committee to see if anyone has any questions. If you could raise your hand or. Okay, well, this is, oh, I do have one. One person
I'll
has.
just say thanks.
Okay,
Nina.
Mr. Braswell, yes.
Oh, sorry, Alderwoman Middlebrook. That was awesome, Nina. Please do send me that paper that you mentioned.
Sure.
I will circulate it. And also, I know that, you seem to say that these laws are kind of like I think there were state level minimum staffing laws, and that these were sort of somewhat toothless. They're not as good as a kind of federal thing, but anything on that or they're good, the state level?
Yeah, I mean, look, if I could get a federal minimum staffing standard, I would. Why fight a fight 50 times if you could fight it once? But from, St. Louis's perspective, if you have the staffing standard at the state level, or you have the staffing standard at the federal level, probably doesn't matter. Right? And so, either way, what you're looking at is trying to make sure both that you have a minimum ratio of direct care staff to residents, and then probably a minimum ratio of certified nurse of RN staff or RN NP staff to residents as well. And Charlene Harrington's work on that is somewhat useful in sort of looking at what those ratios are. But the problem is that if you look at the federal regs on quality of care, they're very much outcomes based, which is to say, you're held responsible for certain outcomes, but then the survey process doesn't really hold you responsible for them, right? And so, one way to do it is try to improve that outcomes based accountability. Another way to do it, and maybe do this simultaneously, is say, well, what's the single most important input in the nursing home space? And the single most important input is staff, right? So if you're having trouble holding people accountable for the outcomes, let's look at what are the inputs we know that really, really matter. And let's require those inputs. And that input is human beings providing care.
Okay, Laura?
Thank you so much. That was a really terrific presentation, and I really appreciated the way you had it organized. And, in terms of local, state, and federal. And we're very hopeful about the federal stuff that may get passed. But yeah, because also it will be hard to get anything passed in Missouri that really strengthens things, because the Missouri legislature is a difficult place to get stuff done. But I appreciate your hope, that message of hope. That's good too. In terms of the local level, the ombudsman, that's great. We usually have the ombudsman on this call. She's at a conference today. But what about local code enforcement? Have you thought about that sort of angle? We've got a lot of issues with bed bugs, raw sewage, failing facilities in terms of their physical structure, heat going out, that kind of stuff. Also just, sort of dietary stuff. Is there anything that we can look at in terms of how the food is being produced. So any thoughts around that would be great.
Yeah, I mean, the good news is that, of course, the federal regulations cover all of that stuff, right? And it's phrased as resident rights, which is one reason I think it can be, especially if you can get a local legal aid involved, be really powerful if you have your ombudsman talking to your legal aid, right? Because the ombudsman's role is as a facilitator, as a mediator, but that doesn't mean they can't hand it off to somebody who will look at this from more of a litigious point of view, right? Or, I mean, what would be super, thinking about trying to build a relationship between the ombudsman, not just legal aid, which is somewhat tied on the wrists in terms of mass advocacy, but local law firms or a local law school clinic too, who can, right? I'm looking at you, SLU, or others, but who can threaten attorney's fees, right? Legal aid can't. Yeah. Right. And sort of trying to help the ombudsman find people who they can refer to, who can carry sticks and not just carrots. And I don't know, I don't know your ombudsman. When I was working in legal aid, I worked with 5 different counties ombudsman. One of them was phenomenal. One of them told me elder, problems didn't exist in their county. There just weren't any. Who knew? I knew there were problems because I was getting the cases, but they didn't see them, right? And then there was everything in between.
I'll speak up and say I'm Annalisa with the St. Louis Area Agency on Aging. So we provide some funding to voice the long-term care ombudsman. And I receive the monthly reports of the outreach that they've done, the visits to the nursing homes, the shared education on residents' rights, and they are doing important good work. We have good quality ombudsmen in the area, but the reality is that the nursing homes are really challenging and that there are not enough staff to meet the needs of residents. And oftentimes we are finding older adults that are living in mixed housing with younger persons with mental health issues. And sometimes there is drug abuse occurring as well. So just very, very much a challenging environment, but they are active, they are in the nursing homes and wanting to be a part of the solution.
Yeah. I guess, which is why my comment is I think the ombudsman program are just phenomenally important and phenomenally good. And so what can you do to help them, to add to their toolkit and allow them to, refer out some of the tough cases and then take on more, because it's drinking from a fire hose, I think, from ombudsman program's point of view.
Okay, thank you. Do we have any more questions or comments for Ms. Cohn?
I do. So are you saying, as an example, the ombudsman program, the local ombudsman program can then refer these situations to a law clinic or a legal services
sure.
of Eastern Missouri? Okay.
Right. So
authority.
I had a really good relationship as a legal aid attorney with one of the ombudsmen. And when she had a case that, she could not resolve through their normal means, she'd call me and I would do an intake.
Perfect.
And so sometimes it was abuse cases, sometimes it was chemical restraint cases. Sometimes, it wasn't a problem with the nursing home per se, but somebody outside the nursing home who was engaging in abuse or, planning that needed to happen, whatever it might be. It allowed that program to basically have someone they could bring these other issues to, freeing her up, but also allowing her to provide services that weren't within her mandate to provide.
Thank you.
Thank you so much, Nina. We really appreciate you. Next up, we have Mr. Maurice Redden.
All right, good afternoon. Thank y'all for inviting me in to talk about topic that is important for me as well. As previously mentioned, I'm a doctor here at St. Louis University School of Medicine. I'm trained in geriatric psychiatry, and I do spend a lot of my time in nursing homes. And we also have our trainees spend time in nursing homes and long-term care facilities as well. So I'd like to speak to you from the clinical aspect of things that we've seen and noticed as well. It's already been mentioned, nursing homes are getting overwhelmed with younger patients and patients with mental health, sometimes untreated mental health illness that can make them a challenging case. And with staff already being short, and being overworked, that can lead to a lot more burden on them as well. So oftentimes we get called in to kind of manage these difficult and aggressive behaviors, but we don't want to over-sedate the patient or over-medicate the patient. That can cause more problems such as falls and impaired memory. So we have to kind of work with the staff. One big thing I know is that staff is maybe not aware of what type of patients that they're getting in a nursing home. They may think they're getting someone with some physical impairments or disabilities, but they also have some mental health issues, and they're not certain on how to deal with that, as well as seeing older patients who have had some long cognitive problems, something like Alzheimer's or Lewy body dementia, so they may experience some behavioral problems from that, as well as they may have hallucinations and they may act out because of that. Staff is not certain how to respond to those behaviors. Oftentimes those patients get kind of sent back out to the hospital relatively quickly. And then in the hospital, they get added on medications that they shouldn't need. So when they come back, they present more of a challenge for myself as well as the staff. I don't know what the solution to that is either, but I think things may get a little more hectic, especially with the population aging, and we're keeping patients alive a lot longer, but we haven't really solved the cognitive deficits of how to approach that. So we may have a lot more patients or people going to nursing homes that may be ill-equipped to care for them, or you mentioned want them over-medicated or chemical castration, things of that nature that we don't necessarily like to do. Let the patient have the best quality of life as possible, even in a nursing home. But most times when I go in, I hear about the troubled patients right away, and some nurses or staff are demanding to have medications put on them that they may or may not need without fully assessing the situation. So that's one difficult thing that I see in my practice and when I take my residents out as well. And then, one thing that I would like to recommend is to have some, I don't know if it could be required or encourage educational sessions for the staff to understand what mental health illness is and how that affects the patients, and if they learn how to deal with their behaviors without using medications, that can make things a little better for the patient and for the staff. That's one thing I thought about that could be helpful. Often see head nurses doing several different jobs because they're understaffed. So if they're spread out thin doing other jobs, they're not able to attend to their job. And one of their jobs is to kind of give us oversight for doctors as well, is to make sure that if they're on medications that require screenings or require us to do frequent assessments on, we can stay up to date on that one. So that way the nursing home won't get in trouble or get dinged for having patients on medications for too long when it's unnecessary. But if the head nurses are running around doing things that they shouldn't be doing, then they're not able to always keep us on our toes from that standpoint. And then we always encourage people to have good mental health awareness even when they're younger. So before you get to a nursing home, you could be on good treatment and make things a little bit easier as well. But that was what I was thinking, and I don't know if I can open the floor for any questions, thoughts, or comments.
Thank you. Does anyone have any questions? Okay, I'm sorry, I'm trying to see whose hand this is.
Mr. Braswell.
Okay, Mr. M. Okay, which, Mr. Braswell? Okay, we'll go with you, Mr.
Yeah.
Braswell first, then you, Mr.
Okay.
Anthony.
That was wonderful. Thank you, Dr. Redden, for talking to us. I guess, let's say two questions. So one would be, have you noticed anything in terms of the pandemic and the situation in nursing homes kind of taking more of a mental health toll on residents and staff? And I guess that's one other question I have, like, do you ever work with staff in terms of mental health needs and things they might be dealing with?
So I guess the second question faster. Unofficially, yes. Like when you go anywhere and I tell anybody I'm a psychiatrist, I automatically get like 2 or 3 patients or people wanting to talk. So once I go into a nursing home, I do talk with the staff sometimes, take them to the side and find out how they're doing, especially during the heart of the pandemic. And it did take a great toll on the residents and the staff. It took a great toll on the residents, mainly because they were not allowed to see their loved ones. And so they got the staff and I guess the world got to see how important social contact is, no matter what stage in life you are or where you are cognitively. Having someone that you're familiar with can be very helpful. And then during the pandemic, of course, there was a lot of staff turnover that created a lot of inconsistencies and broke up routines for patients that knew, Miss Jones, the nurse, was coming at so-and-so time every day, and if she was agitated, this nurse or a staff member could calm this patient down a lot easier than other people would, but they were no longer there. And so that kind of threw everything in a tizzy. And then before we knew about COVID and what to expect and how to handle it, staff they were worried about coming into work, either passing the virus on to their patients or the patients passing it on to them and they taking it home. So from that standpoint, it was like walking on eggshells. And then the patients, needed something. They were already short-staffed. So some patients that I found out later were unfortunately sitting in their rooms being unattended to and in their own body fluids for longer periods of time than need be. And so that puts the patient on, increases their anxiety for the next time that happens, even after the pandemic. They're worried about something going wrong. So the rate of anxiety in the nursing home almost went up tenfold. And so it's a little bit better now, especially the home I go to. Staff tries to be there a little bit more proactive with things, and I can tell the head nurses and the supervisors are talking to their staff members as well, assessing their mental well-being, which I think is one of the silver linings that came out from the pandemic.
Yeah, thank you, Harold, for asking that question. That was one of the questions I wanted to ask. But another question I have is, I believe I heard you say staff needing training or the ability to institute practices that will help people who struggle with mental illnesses without defaulting to medication. Could you cite what some of those practices could be? Because we know from time to time, patients with mental illnesses can be dangerous or create harm, based on their anxiety or what they're going through.
Right. So as I teach the staff and I teach the residents and medical students here, it's always make sure and assess the safety of the situation. So always make sure the patient's in a safe place, even though they're agitated, there's nothing dangerous or violent around them. And then make sure that the staff member yourself is in a safe place. So be closest to the door, but be closest to an opening. And then always use de-escalation techniques. The patient is yelling and shouting. It doesn't benefit anyone if you're going to yell and shout as well. Patients who have severe dementia, they won't do what staff wants them to do. They want to yell at them and try to tell them what to do by yelling. If it was that easy, my job wouldn't exist. So you have to begin to talk to patients in a nice, calm voice. It may be hard of hearing, but you can raise your voice without sounding aggressive or agitated. And then if they're not, threatening to hurt themselves or kill someone, and they're just agitated, yelling, they want something. It's always important to make their needs or wants or their feelings be known, and to kind of give them some validity of what they're going through. And then, especially with my dementia patients or patients who can't express themselves, I always give the example is imagine you're in pain, but you can't use the word pain or any word that resembles pain. You can't point to it. So most people, like babies would do, they would yell or have a temper tantrum, what's going on. So same situation with them. You have to kind of assess the situation, be calm, dim the lights. Oftentimes, people are talking in the halls, it can be loud, you need quiet time. So you want to just keep things calm and talk in a calm voice. Those are things that we always recommend doing as well. If patients like music, that helps calm them down. You're willing to play music for them, things of that nature. If they like talking about their family and they escalate, most patients have pictures of their family on their desk. Begin to, ask them questions or deflect and talking about their family members. Do anything that can calm them down without escalating the situation to where people have to be put in holds and given medication.
Laura? I think you're on mute.
Oh,
Sorry. Thank you very much, Dr. Redden. That was very good, really helpful. One of the things I work with SEIU, which is a labor union, and we represent nursing home workers. And one of the things we've noticed is that, so I have two questions for you. The first one is, how many homes have you noticed that folks actually have the CPI training, that de-escalation training that you were just describing so well? We found that very few of the homes that we represent have actually sent the staff or, gotten CPI training for folks. And we've actually done like where we've had the workers, do a petition, go to the boss as a group, ask for that CPI training. It still doesn't appear very often. So I wondered if that's different in the places where you've been working. And then the second thing is, have you noticed a change in the nursing home population in the facilities you're working at? One thing we noticed when we did a crunch to the CMS data is that patients are younger, far more of them have severe mental illness than in the past, and that there's a real difference in the population since the pandemic, but it was happening even before the pandemic. It's just exaggerated everything. So just wondered those two things. What about CPI training, and then any change in the nursing home population you've noticed?
Yeah, the CPI training, I haven't seen that. I don't believe staff at nursing homes do that anymore. We require it at the hospital, but not at the nursing homes, not required. But that's something that could be maybe an incentive to get the training, you get some bonus as well, but I haven't seen that. And then at the nursing home I go to, we don't take a lot of younger patients. We say younger now, nothing below maybe 50, 55, unless they have some significant, physical or cognitive deficit that we can work with. But when I'm working in the hospital with taking patients from nursing homes, I've seen a lot of younger patients. We even sent a younger patient, even today, he's like 35, to a nursing home. My question was, why is he going to a nursing home? He's not able, he has severe mental health problems, he can't take care of himself. So unfortunately, I think we are getting to the point where, which is good and bad, we're recognizing mental health and mental health conditions a lot earlier, but oftentimes patients have been dealing with mental health problems for years and haven't been able to take care of themselves, and then a loved one dies or their guardian dies and they have no place to go. And most times, most hospitals are just looking for, as we mentioned, any open home that will be willing to take this patient, whether they are appropriate or not.
Okay, is there anyone else who has a question or comment? Yes, Mr. Braswell.
Sorry, and just one more. So, what is the role of a psychiatrist in a nursing home to begin? I mean, I'm just kind of curious, like, how'd you end up working in nursing homes to begin with? Like, are nursing homes required to employ psychiatrists? Is that like a normal thing? And is this through SLU? Is this through SSM? Is this a mission thing? Like what, how common is this? And what, I don't know, like, yeah, what are psychiatrists supposed to be doing in nursing home? And also, out of curiosity, who pays for it, by the way? So are you like paid via Medicaid? Like, who's paying for psychiatric services in a nursing home?
Right. So a lot of questions, but to kind of boil everything down, as a psychiatrist, and I'm trained in geriatric psychiatry, so my training involved going into nursing homes, where most nursing homes, I think they're required to have some type of if they're prescribing psychiatric meds, they need psychiatrists on board, especially what we call the bigger guns, like the antipsychotics. And so primary care doctors don't do that. So most times they need a psychiatrist. And unfortunately, most psychiatrists aren't trained in geriatric psychiatry, so they aren't familiar with what to do. And most of them aren't familiar what to do with patients who are 80, 85 with mental health illnesses, 10 physical problems on how to manage that. And so oftentimes those patients don't always get the best care from my opinion. And so with us going into nursing homes as a geriatric psychiatrist, I always tell people I advocate for the patient. And if they're in a nursing home, I want to make sure they have the best quality of life possible. And oftentimes they're over medicated. And so my job is just to look at medications, make sure they have the proper diagnosis, and then manage those diagnoses with as few medications as possible. And then oftentimes I'll coordinate between the primary care doctor and some other specialties if they have any other physical problems that need to be addressed that may be impacting their quality of life. I think that was all the questions.
And so this is, so sorry, just to clarify, so this is like the facility pays you to sort of
and then
it's not like resident by resident, right? Okay.
Not with me. I know I've worked with other friends on the side in some other long-term care facilities, and they got paid directly from the insurance company, was my understanding. But we have a contract with the nursing. I don't know how they pay us, or where they get the money from to pay the department, my department of psychiatry, but we have a contract with them, and we just go there. We see if they have one patient on this case for us today. If they have 30 patients, we see them. So we don't necessarily get paid by how many patients we see, which is fortunate for us. But every other doctor can't be like that, because if you're in private practice, they make money based on how many patients that they see.
Okay, is there anyone else?
I do have just a
Ms. Richardson?
clarifying question.
Okay, I'm sorry. Go ahead. No, go ahead, and then Ms. Richardson will come to you.
I'm sorry, Ms. Richardson. Would you like to go first? You had your hand up. Okay. So, Dr. Redden, thank you so much for taking time out to speak with us today. I just need a clarifying question. So are you saying that in any nursing home, not just yours, the ones that you visit, but in any nursing home in the state, if a person is on different psychiatric medications, that a psychiatrist needs to be reviewing that with the staff on at least an annual basis?
This is the nursing home that I go to. We review that on a quarterly basis. If they're on certain medications, like there's a big class called the antipsychotics, we have to have certain reasons, certain indications that we use them. And then another class is like Ativan or if they're on Xanax, those benzodiazepines. They have to have certain indications, and there's certain time frames. So each time I go, most of the time the nurse says, hey, they've been on this medication for this long, I need you to review it, and then if possible do a gradual dose reduction, or if not, I need to document on why I think it's still needed. So they do that with us, and that my understanding that is I guess I don't know, it's federal or state policy that should be done if they're on certain classes of medication.
So this could be an example of what our previous presenter talked about with things that are being paid for through Medicaid or
right.
Okay, thank you.
No problem.
Thank you. Ms. Richardson?
Yes. My question is there a way that the nursing homes can be mandated to do the CPI training? Because we have I work in a nursing home as a med tech, and a lot of some of the staff, they don't know how to de-escalate. Sometimes they can make things worse because they don't know.
I don't know if they are make it mandatory or required, but it'd be great if you could. I know it's required for nurses to do that in here in the hospital, work on the psych unit and have that training done. So that is required in the hospital, but I don't know about in the nursing home. If not everybody, like I said, at least, half the staff, or I know some of the head staff should, or, 2 or 3 people each shift on each division should have that training required. Because as you just mentioned, I've seen it several times where they're yelling, they're fussing back at the patient, and they're going back and forth, which makes it worse. And then they both just storm off mad, and that's not a good situation.
Okay, do we have any other questions or comments? Okay, I don't see any. Dr. Redden, we want to thank you for coming and having this conversation with us.
No problem.
We really
Anytime.
appreciate all of the information that you gave us. Thank you so very much.
You're welcome. Am I free to go?
Yes, you are.
Thank you.
Thank you. Okay, committee. So, does anyone want to discuss anything? Does anyone have any comments?
I would like to make a comment. I really would like to, next time when Marjorie Moore is back, to be able to talk with her more about if they have ever in the past worked with any kind of legal consultant on something like this, making charges when someone's, not following the law, and just see if she has, if this is something that they would plan on doing for these cases, and if they haven't, what maybe some of the barriers might be, because just because they don't doesn't mean that, they might need some more support, and would be interested to learn more a little bit about what that would mean for them.
Okay.
Let me just piggyback on that. I'm on faculty in the Center for Health Law Studies at the law school at SLU. And yeah, I'm happy to talk to other people there. There should definitely be a partnership with Voice. And, SLU Health Law Studies is a fantastic department. They're amazing people too, by the way. And, WashU and everyone. And that does seem like sort of low hanging fruit for something that we could do that would be really impactful, like kind of create more relationships like this. And I know the Ombudsman program that, they struggle with what Nina was talking about, the volunteer issue, that volunteers come and go. But if you could have institutional relationships that would produce well-trained volunteers with legal representation reliably, I do think that would be a real game changer.
Sure, I'd like to piggyback on that. I'd be curious to know as well, because when my mother was in the nursing home, I wasn't doing elder law, so I would go to the ombudsman, and they would refer me to law firms, but law firms rarely wanted to touch the nursing home, not unless it was a wrongful death. So I'm just curious to see what that would, how that would help.
Okay, I think those are great questions and comments and ideas. Having a grandparent who was in the nursing home, we actually my grandparents had 7 kids, so we rotated shifts, and then grandkids. So those of us who were adults, we rotated. So when my grandfather was in a nursing home, there was someone always there to do. So he didn't have those issues, but we saw other residents who did. So, yeah, I think that would be great. Do we have any more questions or comments? Yes, Harold?
So I invited Andrew Wang to come next week to talk about maps. I don't know if anybody else has come. Is anybody else set for next week other than Andrew?
I don't have my notes from last week, but I am going to contact the building division to see if they can come next week, so we can have that discussion about how they're handling inspections. And I apologize. Someone has been swatting my child's school district today. And they finally realized that it was just a prank, but my nerves have been on 10. That's not fun, thinking someone's getting ready to harm your child or their school. So, but those are the 2 that we have for next week. And if anyone has anyone else that may want to come, I can push the building division back and we can have discussions with other people.
I have a commitment from Nathan Dell from Places for People for the 10th of April. So
Okay.
that would not conflict. I'm so sorry that you had to go through that, Chair Middlebrook. That sounds like a terrible, terrible day.
Thank you. Thank you. Okay, so if we have no further discussion, Madam Clerk, can you please call off the people who were not here?
Yes, ma'am. We had Alderwoman Davis, Alderwoman Boyd, Lenny Jones, Marjorie Moore, Victoria Ann Rory, Danielle Spradley, Chris Beckley, Tasanya Johnson, Cindy Jackson.
Okay, we will go ahead and excuse those individuals for necessary absence. I'm sorry, I'll go back. Do we have any announcements for this week? Okay, seeing that there are none, we will go ahead and adjourn today's meeting. Everyone be safe and have a great week, and we will see you next Monday. Thank you.